My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm a professor of radiation oncology, where I'm chief of the cardiothoracic radiation oncology service, and as well as director of clinical trials. Superior vena cava syndrome is a syndrome that exists when the superior vena cava is compressed, in this case, implicitly through progression of non-small cell lung cancer, either from the primary lesion itself or sometimes from the lymph nodes. The consequences of superior vena cava syndrome actually can be somewhat numerous. There's not a single component to that syndrome. Depending on how quickly the compression occurs and the extent of the compression, patients can have symptoms from facial plethora and swelling. They can develop clots and the associated vessels draining through into the vena cava. They can develop additional channels of vessels that then become more prominent on the chest and otherwise. Collateral vessels that can become then uncomfortable, but then also just visually concerning to the patient. None of those things are true emergencies, although classically it's been placed in that category. The few circumstances that are true emergencies are when you can actually get laryngeal swelling or rapid neurologic deterioration because of how quickly you can change the ability to drain the venous system into the heart. In the past, superior vena cava syndrome was the purview of the radiation oncologists. A patient would come in with compression, they would call us, and we would initiate urgent radiotherapy. However, over the years, as we've improved our ability to manage these patients earlier, such as with stent placement through the intravascular approach, or just by expectant management of their symptoms, it's given us the opportunity to step back, take a pause, and do the right thing for the patient. Because many of these patients, when they present, may not necessarily have disseminated disease, and so staging them appropriately is critical. If you embark on a rapid, reactive course of palliative radiation to this area, only to find out that they actually don't have metastatic disease, you've greatly complicated their ability to undergo curative intent therapy. So at our institution, if a patient comes in with these symptoms, unless they are undoubtedly with disseminated disease with a diagnosis that we can clearly point to, we often manage them with stent placement or with other management of their symptoms, properly stage the patient, achieve a diagnosis, and then embark on therapy afterwards. In a patient who does have superior vena cava syndrome, who does have metastatic disease, traditional palliative regimens are the norm. Single doses, 5 fraction doses, or 10 fraction doses are often the most appropriate based off of ASTRO consensus guidelines and others. However, in those patients who present with superior vena cava syndrome, as their mechanism of becoming attention for their stage 2 or 3 lung cancer, definitive chemoradiotherapy or sometimes surgical approaches in a curative intent setting are the most appropriate.